Question 1. On the same day as a scheduled minor procedure, e.g., wart removal, a patient also complains of a new, unrelated problem, e.g., severe ear pain, which the physician diagnoses and manages. The physician performs a problem-focused history exam and makes a medical decision. Which modifier should be appended to the evaluation and management E/M code? A. 24. B. 25. C. 57. D. 59. Answer: B. 25. This scenario tests the correct use of modifier 25, which indicates a significant, separately identifiable evaluation and management E/M service by the same physician on the same day of a procedure. The key is that the E/M service for the new, unrelated problem, ear pain, was distinct from the pre-planned minor procedure, wart removal. Modifier 25 tells the payer that the E/M service went above and beyond the usual preoperative and postoperative care included with the procedure. For example, if a patient comes in for a scheduled injection but also has a new rash evaluated, the E/M for the rash would get modifier 25. Here's a tip: think of modifier 25 when the doctor does double duty, a planned procedure plus an unplanned, separate E/M service. Question 2. A patient is seen for scar contracture of the right hand, which resulted from a third-degree burn sustained 2 years ago. What is the correct sequencing of the ICD-10-CM codes? A. Code the burn first, followed by the scar contracture. B. Code only the scar contracture. C. Code the scar contracture first, followed by the burn code with a 7th character S. D. Code the burn with an A4 initial encounter, then the scar. Answer: C. Code the scar contracture first, followed by the burn code with a 7th character S. This question tests the proper coding for a sequela, which is a late effect of a previous injury or illness. The key clue is that the current problem, scar contracture, is a result of a past event, a burn 2 years ago. Guideline I.C.19. states that for sequela coding, the code for the condition or nature of the sequela is sequenced first, followed by the original injury code with the 7th character S, for sequela. For instance, coding pain due to an old fracture would require the pain code first, then the fracture code with the S extender. Always remember the rule for late effects: code what the patient has now first, then code what caused it with an S. Question 3. A patient has a medical imaging report describing a slice that divides the body into anterior and posterior portions. Which anatomical plane is being described? A. Sagittal. B. Transverse. C. Coronal. D. Oblique. Answer: C. Coronal. This question assesses knowledge of anatomical planes, which are fundamental to understanding medical imaging and procedural descriptions. The keywords anterior, front, and posterior, back, portions are the definitive clue for the coronal plane, also known as the frontal plane. The coronal plane runs vertically and divides the body into a front and back section, like a crown sitting on a head. For contrast, a sagittal plane divides the body into left and right sides, and a transverse, or axial, plane divides it into upper and lower parts. A helpful way to remember is, a coronal plane separates the crowd in front of you from the people behind you. Question 4. A coder finds and excludes one note under code category K57, diverticular disease of intestine. The note lists K55.0, acute vascular disorders of intestine. What does this excludes one note mean? A. The two conditions are unrelated and can be coded together. B. The condition listed in the note should be coded first. C. The two conditions cannot be coded together under any circumstances. D. The condition listed in the note is an integral part of the condition above it. Answer: C. The two conditions cannot be coded together under any circumstances. This question tests the understanding of the excludes one note, a critical instructional note in the ICD-10-CM codebook. An excludes one note signifies not coded here and means the two conditions it links are mutually exclusive and should not be reported together for the same encounter. The two conditions cannot occur at the same time, such as a congenital versus an acquired form of the same condition. For example, an excludes one note under a code for an acquired absence of a limb would prevent you from also coding a congenital absence of that same limb. A simple way to remember is, excludes one means one code or the other, but never both. Question 5. A pathology report for a gallbladder specimen states, the specimen is received in formalin, labeled with the patient's name. It is a 7.5 cm pear-shaped gallbladder with a smooth, glistening serosa. The wall thickness is 0.2 cm. The lumen contains multiple yellow-faceted stones. Which part of the examination is this describing? A. Microscopic examination. B. Special staining. C. Clinical consultation. D. Gross examination. Answer: D. Gross examination. This question tests the distinction between the different stages of a pathology examination. The key is that the description focuses on what can be seen with the naked eye, the size, shape, color, and texture of the specimen and its contents, pear-shaped, smooth, multiple yellow-faceted stones. This visual inspection is known as the gross examination. A microscopic examination, by contrast, would describe the cellular structure of the tissue as viewed under a microscope. Think of it this way: gross in this context means large scale, or what you can see without magnification. Question 6. A patient with type 2 diabetes mellitus presents with a new diagnosis of diabetic polyneuropathy. How should this be coded in ICD-10-CM? A. Assign one code for type 2 diabetes and a separate code for polyneuropathy. B. Assign one combination code for type 2 diabetes with polyneuropathy. C. Assign only the code for polyneuropathy as the primary diagnosis. D. Assign the code for type 2 diabetes with a use additional code note for the manifestation. Answer: B. Assign one combination code for type 2 diabetes with polyneuropathy. This question focuses on the use of combination codes in ICD-10-CM, a core coding principle. The keywords diabetic polyneuropathy indicate a direct cause and effect relationship between the diabetes and the neuropathy. ICD-10-CM has specific combination codes that capture both the underlying disease and its manifestation in a single code, making it unnecessary to code them separately. For instance, instead of coding E11.9, type 2 diabetes mellitus without complications, and G62.9, polyneuropathy, unspecified, you would find a single, more specific code like E11.42, type 2 diabetes mellitus with diabetic polyneuropathy. Always look for a combination code first when a diagnosis states a condition is due to or with another condition. Question 7. According to the 2021 and later E/M guidelines for office visits, which of the following is not one of the three elements used to determine the level of medical decision-making, MDM? A. Number and complexity of problems addressed. B. Amount and/or complexity of data to be reviewed and analyzed. C. Risk of complications and/or morbidity or mortality of patient management. D. The extent of history and/or examination performed. Answer: D. The extent of history and/or examination performed. This question tests knowledge of the updated evaluation and management, E/M, guidelines, specifically the components of medical decision-making, MDM. Under the guidelines effective in 2021 for office visits and later expanded, the level of MDM is based on three core elements: problems, data, and risk. The key change was that the history and physical exam components are no longer used to select the overall E/M level. Instead, the exam must only be medically appropriate for the visit. For example, a high-level visit can be coded based on complex MDM even if the physical exam was very focused. Remember this major shift. For modern E/M coding, MDM, or total time, drives the code level, not the amount of documentation for history and exam. Question 8. A patient sustains a laceration of the left Achilles tendon. The correct ICD-10-CM code is S86.012, but it requires a 7th character for the encounter type. If this is the initial encounter, which of the following is the correct code? A. S86.012A. B. S86.012XA. C. S86.012XA. D. S86.012.A. Answer, B. S86.012XA. This question tests the proper use of the placeholder X in ICD-10-CM coding. The crucial detail is that some codes, like S86.012, laceration of left Achilles tendon, are only 6 characters long but require a 7th character extension, like a for initial encounter. To ensure the extension is in the correct, 7th, position, a placeholder X must be added to fill the empty 6th character spot. Adding the X maintains the standard 7-character structure required for these codes. Think of the X as a space saver that holds the spot so the encounter digit can be in its proper place. Question 9. A patient sees Dr. Smith, a cardiologist, for the first time. The patient had previously seen Dr. Jones, a different cardiologist in the same group practice, for the same condition 2 years ago. How should this patient visit with Dr. Smith be classified for E/M coding? A. New patient. B. Established patient. C. Consultation patient. D. Outpatient follow-up. Answer, B. Established patient. This question tests the definition of an established patient, a key concept in evaluation and management, E/M, coding. The crucial detail is that the patient saw a physician in the same group practice with the same specialty within the last 3 years. Even though the patient is new to Dr. Smith, they are considered established to the practice because they saw Dr. Jones, another cardiologist in that group, 2 years ago. For example, if you see an internal medicine doctor at a clinic and then see a different internal medicine doctor at the same clinic a year later, you are an established patient for that second visit. Remember this tip: a patient's status, new versus established, is tied to the entire group practice and specialty, not just the individual doctor. Question 10. A radiology report for a CT scan of the abdomen states that oral and intravenous contrast was administered. How should this study be coded? A. CT abdomen without contrast. B. CT abdomen with contrast. C. CT abdomen without contrast, followed by with contrast. D. CT abdomen, limited. Answer, B. CT abdomen with contrast. This question tests the definition of a with contrast study in radiology coding. The key phrase oral and intravenous contrast was administered directly points to the correct coding choice. A study is coded with contrast if contrast material is administered intravenously, intra-articularly, or intrathecally. Oral and or rectal contrast administration alone does not qualify a study as with contrast for CPT coding purposes, but when combined with for contrast it is part of the with contrast service. For example, if only oral barium was given for an abdominal CT, it would be coded without contrast, but the addition of for contrast makes it a with contrast study. Remember the rule: for CPT, with contrast almost always implies for intra-articular or intrathecal administration. Question 11. A coder notices that a National Correct Coding Initiative, NCCI, Procedure to Procedure, PTP, Edit exists for two CPT codes billed on the same date of service. The edit has a modifier indicator of 1. What does this indicate? A. The two codes can never be billed together. B. The two codes can be billed together if a specific modifier is used and criteria are met. C. The codes are bundled, but no modifier is ever allowed. D. The edit is informational only and does not affect payment. Answer: B. The two codes can be billed together if a specific modifier is used and criteria are met. This question tests understanding of NCCI/PTP edits and their modifier indicators, which are crucial for billing compliance. A modifier indicator of 1 signifies that a modifier, like modifier 59, can be used to bypass the edit if the two procedures were truly separate and distinct. This is different from an indicator of 0, which means the codes are permanently bundled and can never be reported together. For example, an excision of one skin lesion and a biopsy of a separate lesion on a different body part might trigger a PTP edit with indicator 1, allowing the use of a modifier to show they were separate sessions. A good tip is to think of 1 as 1 chance to explain with a modifier, while 0 means 0 chance. Question 12. A physician performs a biopsy of a skin lesion on the patient's back and also excises a completely separate, distinct lesion on the patient's arm during the same encounter. Both procedures have an NCCI/PTP edit. Which modifier would be appropriate to append to the code for the second procedure to indicate it was a separate site? A. 25. B. 51. C. 59. D. 76. Answer: C. 59. This question tests the application of modifier 59, which identifies a distinct procedural service. The keywords are separate, distinct lesion, and separate site, which are the primary criteria for using this modifier. Modifier 59 is used to indicate that a procedure or service was independent from other services performed on the same day, such as being performed on a different anatomical site, in a different session, or for a different injury. For example, if a surgeon repairs a tendon in the hand and also debrides a wound on the leg, modifier 59 would be attached to the debridement code to show it wasn't part of the tendon repair. Remember, modifier 59 is a modifier of last resort. Only use it if no other, more specific modifier, like RT, LT, or the XE/XS/XP/XU modifiers, accurately describes the situation. Question 13. A patient receives an injection of 30 mg of drug XYZ in a physician's office. The HCPCS Level 2 code description for drug XYZ is J1234, injection, XYZ, 10 mg. How should this service be coded? A. J1234X1. B. J1234X3. C. J1234 with a note specifying 30 mg was given. D. A different J code for a 30 mg dose. Answer: B. J1234X3. This question assesses the correct way to report units for drugs administered from a multi-dose vial, a common task in HCPCS Level 2 coding. The key is to compare the dosage given, 30 mg, to the dosage in the code description, 10 mg. To determine the number of billable units, you divide the amount administered by the amount listed in the code description, 30 mg/10 mg equals 3. Therefore, you report code J1234 with 3 units in the quantity field of the claim form. A practical tip is to always double-check the dosage unit in the HCPCS code description before calculating the final quantity to bill. Question 14. A patient undergoes a cholecystectomy. Based on the suffix ectomy, what was done to the gallbladder? A. It was incised, cut in two. B. It was surgically repaired. C. It was surgically removed. D. A new opening was created into it. Answer: C. It was surgically removed. This question tests knowledge of common medical suffixes, which are essential for understanding procedure names. The suffix ectomy means surgical removal or excision. The root word cholecystectomy refers to the gallbladder, so a cholecystectomy is the surgical removal of the gallbladder. Other related suffixes are otomy, to cut into, like a tracheotomy, and ostomy, to create a new opening, like a colostomy. A great tip for learning terminology is to break down long words into their roots, prefixes, and suffixes to figure out their meaning. Question 15. When must a provider issue an advance beneficiary notice of non-coverage, ABN, to a Medicare patient? A. For all services provided to a Medicare patient. B. After a service has been provided and denied by Medicare. C. Before providing a service that the provider believes may not be considered medically necessary by Medicare. D. Only for services that are statutorily excluded from Medicare coverage, like cosmetic surgery. Answer: C. Before providing a service that the provider believes may not be considered medically necessary by Medicare. This question is about the correct timing and purpose of an advance beneficiary notice, ABN, a critical Medicare compliance document. The key concept is that an ABN must be issued before providing a service that is usually covered but may not be considered medically necessary for this specific patient. The ABN informs the patient that they may be financially responsible for the service if Medicare denies the claim, allowing them to make an informed decision. An ABN is not required for services that are never covered by Medicare, statutorily excluded. A helpful way to remember is, ABN stands for advance notice, meaning it must be given ahead of time to be valid. Question 16. A patient is diagnosed with stage 3 chronic kidney disease, CKD, and the provider documents that it is due to the patient's long-standing hypertension. How should this be coded? A. Code hypertension first, then stage 3 CKD. B. Code stage 3 CKD first, then hypertension. C. Code only the hypertensive chronic kidney disease. D. Assign a combination code for hypertensive chronic kidney disease and a second code for the stage of CKD. Answer: D. Assign a combination code for hypertensive chronic kidney disease and a second code for the stage of CKD. This question tests the specific ICD-10-CM guideline for coding hypertension and chronic kidney disease, CKD. The keyword due to establishes a cause and effect relationship, which directs the coder to use a combination code from category I12, hypertensive chronic kidney disease. The guideline then requires a second code from category N18 to specify the stage of the CKD. For this patient, you would assign I12.9, hypertensive chronic kidney disease with stage 1 through stage 4 chronic kidney disease, or unspecified, followed by N18.3, chronic kidney disease, stage 3. Remember this two-code rule: when hypertension causes CKD, you need one code for the relationship, I12, and a second code for the stage, N18. Question 17. Under which of the following circumstances is it appropriate to use an unlisted procedure CPT code? A. When a procedure is new and not yet assigned a specific CPT code. B. When the coder cannot find the correct code in the index. C. When a more specific code exists but pays less. D. When the documentation is poor and does not support a specific code. Answer: A. When a procedure is new and not yet assigned a specific CPT code. This question addresses the proper use of unlisted CPT codes, which is governed by strict rules. The only valid reason to use an unlisted code is when no specific CPT or HCPCS code exists to describe the procedure performed. These codes should not be used as a shortcut for difficult-to-find codes or due to poor documentation. For example, if a surgeon uses a brand new surgical technique that has not yet been assigned a CPT code, an unlisted code from the appropriate body system section would be reported along with a detailed report. Think of unlisted codes as a last resort, reserved only for procedures that are truly unique or new to medicine. Question 18. When describing the location of the wrist in relation to the elbow, which term is most accurate? A. Proximal. B. Distal. C. Medial. D. Anterior. Answer: B. Distal. This question assesses the use of anatomical directional terms, which are fundamental for accurately describing locations on the body. Distal means farther away from the point of attachment or origin of a limb, while proximal means closer. Since the wrist is farther from the shoulder, the limb's point of origin, than the elbow is, the wrist is distal to the elbow. For instance, the fingers are distal to the wrist, and the elbow is proximal to the wrist. A good way to remember is, distal sounds like distant, meaning farther away from the body's trunk. Question 19. A physician excises a 1.5 cm benign skin lesion from the neck and performs a simple, one-layer closure. How should this be coded? A. Code the excision only. B. Code the excision and a separate code for the simple repair. C. Code the simple repair only. D. Code an intermediate repair. Answer: A. Code the excision only. This question tests the CPT guidelines for coding lesion excisions and their associated repairs. The key concept is that a simple repair, closure, is always included in, or bundled with, the code for the lesion excision and is not reported separately. Only intermediate or complex repairs can be coded in addition to the excision. Because the documentation specified a simple, one-layer closure, the coder should only select the appropriate CPT code for the excision of a benign lesion of that size and location. Always remember that a simple repair after an excision is considered part of the package and is not separately billable. Question 20. A urine dipstick test is performed in the office to check for the presence of glucose. The result is simply reported as positive or negative. What type of laboratory test is this? A. Quantitative. B. Qualitative. C. AG. D. Cytopathological. Answer: B. Qualitative. This question differentiates between two fundamental types of laboratory tests, qualitative and quantitative. A qualitative test determines the presence or absence of a substance, yielding a simple positive or negative result, as seen in the urine dipstick test example. In contrast, a quantitative test measures the exact amount or concentration of a substance, providing a numerical value, e.g., a blood glucose level of 110 mg per deciliter. Think of it this way: qualitative analysis answers what, or is it there, while quantitative analysis answers how much. Question 21. For a new patient office visit, 99204, a physician documents spending 50 minutes of total time on the day of the encounter, including reviewing records, examining the patient, and counseling. The CPT codebook states the time threshold for 99204 is 45 to 59 minutes. Is it appropriate to code this visit based on time? A. Yes, because the total time falls within the range for 99204. B. No, time can only be used if counseling dominates the visit. C. No, time can only be used for established patients. D. Yes, but only if the medical decision-making was also at a moderate level. Answer: A. Yes, because the total time falls within the range for 99204. This question tests the modern rules for time-based E/M coding for office visits. Under the current guidelines, an office visit E/M code can be selected based on either the total time spent by the provider on the date of the encounter or the level of medical decision-making, MDM. The old rule that counseling must dominate over 50% of the visit no longer applies to these codes. Since the physician's 50 minutes of documented total time meets the 45-minute threshold for code 99204, it is appropriate to select this code based on time alone. Remember the current rule: for office visits, you can use either total time or MDM to pick your level. Question 22. For a diagnostic test performed in a hospital outpatient setting, the Medicare Rule for direct supervision requires that the supervising physician be A. Immediately available in the office suite. B. Present in the room where the procedure is being performed. C. Reachable by telephone. D. On the hospital campus and immediately available to furnish assistance. Answer: A. Immediately available in the office suite. This question tests the definition of physician supervision levels for diagnostic tests, a key compliance concept in radiology and other specialties. For Medicare billing in an outpatient or physician office setting, direct supervision means the physician is present in the office suite and immediately available to provide assistance and direction throughout the performance of the procedure. This is less intense than personal supervision, physician in the room, but more stringent than general supervision, physician must be available but not necessarily on-site. For example, a technician can perform a test under direct supervision as long as the physician is physically present in the same office suite. A simple tip is to associate direct with being directly on-site in the office. Question 23. A surgeon performs a cholecystectomy that is significantly more difficult and takes 90 minutes longer than usual due to extensive adhesions from a previous surgery. The surgeon's operative report clearly documents the increased physician work and complexity. Which modifier could be appended to the cholecystectomy CPT code? A. 22. B. 52. C. 53. D. 62. Answer: A. 22. This scenario tests the correct application of modifier 22, which stands for increased procedural services. The key clues are significantly more difficult and 90 minutes longer than usual, supported by detailed documentation of the extra work involved. Modifier 22 is used to inform the payer that the work required to perform a procedure was substantially greater than what is typically required, which may warrant additional payment. This modifier should never be used lightly and always requires a detailed report explaining why the service was more difficult. A good tip is to reserve modifier 22 for truly exceptional cases where the procedure was above and beyond the ordinary. Question 24. A patient is treated in the emergency department for a fractured arm sustained when they fell from a ladder at their single-family home. Which of the following is true about coding the external causes for this injury? A. External cause codes are never mandatory. B. An external cause code should be the first listed or principal diagnosis. C. External cause codes should be reported to describe the cause, place, and activity related to the injury. D. Only one external cause code can be reported per encounter. Answer: C. External cause codes should be reported to describe the cause, place, and activity related to the injury. This question tests the guidelines for using external cause codes, V00Y99, which provide valuable data about injuries and poisonings. The correct guideline is that you should use multiple codes, as needed, to fully describe the circumstances, one for the event itself, e.g., fall from a ladder, one for the place of occurrence, e.g., home, and one for the activity, e.g., while doing home repairs. External cause codes are never the principal diagnosis, they are always listed after the primary injury code, the fracture. Although not universally required by all payers, reporting them is a best practice and is mandated by some states or specific insurance policies. Question 25. A patient with chronic respiratory failure is prescribed home oxygen equipment. The company that provides the equipment and related supplies to the patient for use in their home is known as what type of supplier? A CLIA-certified laboratory. B. A participating physician provider. C. A DMEPOS supplier. D. An ambulatory surgery center. Answer: C. A DMEPOS supplier. This question tests the terminology for suppliers of specific medical items, a key part of HCPCS Level 2 coding and billing. The acronym DMEPOS stands for Durable Medical Equipment, Prosthetics, Orthotics, and Supplies. The home oxygen equipment described is a classic example of durable medical equipment, DME. Therefore, the company providing these items is a DMEPOS supplier, which bills Medicare and other payers for these specific types of products. Think of DMEPOS as the category for all the hardware and supplies a patient might use at home, from wheelchairs and walkers to oxygen tanks and diabetic test strips.